Okay, good afternoon. Thank you to the organizers for this meeting. I think it's getting better and better every year. And by the way, thank you to the translator who helped me the day out. Otherwise, I would have been lost with the Spanish language. And talking about micro-ultrasound, I have to thank Giovanni for his, or congratulate him for his work with keeping up this method and evaluating it. So we heard a lot of the micro-ultrasound. Before I start, as being the chairman of the European Society of Urological Imaging, I would inform you that we have a meeting at the UN. I would like to see some of you being there. It's going to be a very interesting program, Future Preventive Strike Back, so it deals with antibiotics, the upcoming resistance of antibiotics, and what to do wise in case what happens that the second thing I would like to use the in conjunction with the thing in November, and also this is a very nice meeting. It's gaining more and more interest, so I would like to see some of you at the meeting. So my talk is about PIRAD3 lesions, and at one of these meetings there was a special issue to PIRAD3 lesions, and stated by Professor Hartwig, who's very known for multiparametric studies. He said that the amount of PIRAD3 lesions defined by the urologist should be lowered as a clear statement of which meant to biopsy or not. So why is it? What is PIRAD3? It means nothing. It means probably nor nothing. The question with those patients is to biopsy or not to biopsy. If we go to the literature, we can say no, we do not need to. Let's accept a 6.5 negative false rate. If you look to this study from a group from Australia, so they had all patients having a lesion, PIRAD3 lesion, and they did a biopsy on them, and almost every biopsy was benign, so 93.5% benign, just 6.5% false negative. I think this is rather acceptable, so we could say if it's a PIRADS 1, 2, or 3, we can say we do not need a biopsy. If you look to another literature, this is a group from US, they did the same, and they had the detection of clinical significant cancer of 17%. So the answer is, if you got a PIRAD3 lesion, yes, do a biopsy. Do not accept at least 17% missed significant cancers. And if we look to the picture study, which I think is the best study for multiparametric MRI ever, because they didn't compare MRI with biopsies, but with template biopsies, so that means more accurate like a radical prostatectomy. If you go to PIRAD3 lesions, you see in red significant cancer detection. It's up to 20%, and the yellow part in combination with the red part, so the significant and the so-called clinical insignificant cancers, the detection rate would be 80% of patients would have the diagnosis of cancer if you would diagnose. So I think multiparametric MRI is to date the most or the best thing we have. It's standardized and easy to use, even for us urologists, so we can send the patient to the radiologist and he will do everything for us. But it lacks of sufficient accuracy. And we do have good alternatives. We heard something about that, like biomarkers, nomograms. But in terms of imaging, we do not have a standardization if it comes to ultrasound. And I wonder who of you is interested in ultrasound and is doing so in his patient. So the problem with PIRAD3 lesions, if you get a report from the radiologist, 29% of MR are positive for PIRAD3. That means equivocal lesions. The precision trial, which was out last year, told us that we should not biopsy MRI negative cases. I told you before what happens if you do not do a biopsy on PIRADS 1, 2, or 3. You will miss a lot of significant cancers. So the question is, do PIRAD3 require biopsies? Yes, it is, but anyhow, there might be something which can rule out or be more precise in conjunction with PIRAD3 lesions what to do. So why micro-ultrasound? We heard about the technique itself by Giovanni. So I do not have to show you again. He showed us the public more and the data are getting more robust. There is an improvement in the quality and sensitivity and specificity of the micro-ultrasound. We saw this one of Giovanni, so that it is even as good as multiparametric MRI. And it might be, this is something from Canada, more sensitive than multiparametric MRI in active surveillance cohort patients. So if you monitor those patients, is it loud enough? Okay. If you monitor those patients with Gleason 3+3 or at least the low volume Gleason 3+4, you won't see them in MRI, but maybe in micro-ultrasound. Okay, so coming to the study, and this is actually what has been done in 6 institutions, patients with PIRAD3 lesions, so 41 patients with PIRAD3 lesions. 19 of those had benign tissue in the biopsy, 11 Gleason 6, and the other 11 a Gleason score higher than 6, so significant cancer. If you do micro-ultrasound on those, you will get only 15% where it's equivocal, so no help. That doesn't mean it's probably benign or probably malignant, so you have to do a biopsy on those. But it's so detailed that you get informations in a lot of patients, like primus below 3, that means there won't be cancer, or primus higher than 3, there's a high chance that there's cancer. That you can see in the left column, primus lower than 3, 9 patients were benign and just 2 had a Gleason 6 and just 1 was significant cancer. So out of the 41, if it's a primus below 3, I think the risk is very low that you will lose just 1 patient of this cohort having a significant cancer. But if it comes to a primus higher than 3, and that means the risk is high or very high of having cancer in this PIRAD3 group, so a group where the radiologist didn't know what to say, the positive predictive value for the primus scoring 4 and 5 was 70%, and the good news is the negative predictive value was 75% for primus 1 and 2, and for the highest or significant cancer, if you define it as Gleason score higher than 6, it was 92%. So I think that to date, the additional use of micro-ultrasound in those patients, and it's like not 29% when we look at the data I showed you, you could get informations and potentially avoid biopsies. You just have to say to the patient that we are to date not at 100%. So this is just a case where you can see in the MRI a PIRAD3 lesion where the error is, and the same patient, and this was done in the study, you can see a PIRADS 4 to 5 lesion, primus, sorry, here. Oh. This one here. And so there was a Gleason 3+4, so this was a true positive primus 4 to 5 high-risk prostate cancer due to micro-ultrasound, which was misclassified by MRI. Thank you very much.